Hello, everyone from Igenomix Future Life Group. We're so excited to present to you today our third part to our PGT-A webinar series, Clinical Observations and Advantages with Advanced PGT-A Technology. And we're super excited to have two guest speakers here today to present. We have Jason Au, Regional Laboratory Director for PCRM in Canada, and Dr. Arlene Morales. As I mentioned, this is our third part to our webinar series, so I hope you've had a chance to see the first two. If you haven't, no worries. They are recorded on our website and you can access them at any time. Similarly, today's webinar will be recorded as well. We have almost 200 registrants, some of whom we know will be looking forward to watching the recording later on today. Just a brief introduction to Vitrolife Group. Many of you know us and love us as Igenomix. We were acquired by Vitrolife and we maintain the two legacy brands, Igenomix and Vitrolife Group. Igenomix and Vitrolife under the brand of Vitrolife Group. So first, I'd like to start by introducing our first guest speaker today. You may know Jason Au. He earned his master's degree in clinical embryology from the University of Leeds and his bachelor's in science and biochemistry and chemistry from the University of British Columbia. He is currently pursuing his PhD in reproductive clinical science at Eastern Virginia Medical School with a research focus on non-invasive PGT-A. Jason is a CFAS certified laboratory director and serves on the board of directors of the Canadian Fertility and Andrology Society. In his role as regional laboratory director at Pacific Centre for Reproductive Medicine in Western Canada, he oversees multiple sites and laboratory teams. His work is dedicated to advancing laboratory technology and integrating AI-driven innovations to improve clinical outcomes in assisted reproduction. Jason, welcome and thank you so much for participating in our webinar today.
Thank you.
And before we give the floor to Jason, I'm going to also take the moment to introduce our second guest speaker, Dr. Arlene Morales. Dr. Morales is a board-certified reproductive endocrinologist in San Diego in California. She earned her medical degree from Johns Hopkins University School of Medicine and completed her fellowship in reproductive endocrinology at UCSD. She spent her early professional life on faculty at UCSD, then as the IVF director at Emory University. In 2000, she founded Fertility Specialist Medical Group, or FSMG, where she serves as the medical director. Her professional interests have been focused on the intersection of patient care, bioethics, and technology. Having served as the bioethics chair of American Board of Obstetrics and Gynecology, she continues her interests as the bioethics chair of Sharp Memorial Hospital. So Dr. Morales, welcome and thank you so much for presenting today. And Jason, if you would like to go ahead and take the floor, you can start with your slides.
Great, thank you. Thank you, Lisa. Thank you for the warm introduction, and thank you for the Vitrolife Group for this opportunity to present and share my experience with PGT-A Plus. So a quick disclosure, as Lisa has mentioned in my introduction, I'm the Regional Lab Director at PCRM, and I'm the member of Board of Directors at CFAS, Canadian Fertility Society. So, move on to the next slide. There. So today I'm gonna focus on the clinical and laboratory implementation of PGT-A Plus. There are four main pillars that I want to go over. They are clinical benefits of PGT-A Plus, how we're gonna incorporate staff and patient education in a smooth implementation of the test. I think what I'm gonna spend most of the time on is talking about the expectation of the PGT-A Plus outcome and also how to respond to these rare occurrences of outcomes. Last but not least, I'm going to talk briefly about KPI monitoring and how we follow up to make sure a smooth implementation has taken place. So As Alisa had mentioned, this is the third part of a webinar series. On the first two parts, Alisa and Angela have spent a significant amount of time talking about the clinical benefits of PGT-A Plus. So here I'm just going to do a quick recap. There are three main clinical benefits. First is pleurisy screening. As all of us have already know, about 1% or less than 1% of the normally fertilized oocytes, what we usually call in the lab 2PNs, are either haploid or triploid. So this test will able to identify them on top of our standard PGT-A testing and allows to deselect them from transfer. The other benefit with the pleurisy screening is to potentially rescue abnormally fertilized oocytes. If your practice do culture 0PN, 1PN, and 3PN to the blastocyst stage and perform biopsy, this test also will be able to confirm that these embryos are diploid and potentially be used for embryo transfer, overall increasing the pool of embryos that is available for transfer for patient. And the second benefit is contamination detection. What this test does is detect the presence of a mixture of DNA from two sources. A lot of times, what we consider DNA contamination, external DNA contamination source, they're euploid. So what this test does to avoid is to avoid masking aneuploid embryos to report it as mosaic. Also, as additional safeguard, it also provides a cohort sibling QC check. What it does is confirm all embryos when there's more than one embryo or biopsy sample in the cohort originate from the same gamete source. Effectively, all three tests combined, they're really there to enhance the reliability and clarity of the PGT-A outcome. And the goal is to support a greater confidence and informed interpretation by the healthcare professionals like ourselves. And what this leads to is a better counseling and informed decision for our patient when we go over PGT-A outcomes. Moving on to staff and patient education, I know Dr. Morales is going to spend a little more time talking about this, so I'm just going to briefly touch on this. We need to get all the staff involved. That include physicians, nursing, laboratory, and operations. All staff need to have a great understanding of what the benefit of PGT-A Plus, I already recapped it earlier on the last slide, and have adequate knowledge to confidently answer patients' questions. If we're not able to address and confidently answer patients' question, they will not have confidence in the test, not let alone all these add-on that we're thinking have great potential benefit for the patient. Another consideration is the cost, right? PGT-A Plus does come with additional costs, so you need to work with your operation teams to decide whether the clinic is absorbing the cost of PGT-A Plus or the cost is being passed on to the patient. So definitely talk to your operations team, and again, understanding the benefit of PGT-A Plus will go a long way in that decision making. Another point is decide whether you want to provide PGT-A Plus as an individual case basis or all cases. From my personal perspective, I think implementing across all cases would be most, it will enable a most smooth transition. The reason being is it alleviates a lot of administrative burden on the clinical team to making sure the patient's request has been adequately addressed. And it saves a lot of time for the physician and genetic counselor explaining the nuance between PGT-A standard and PGT-A Plus in assisting the patient with the decision on whether to opt out PGT-A Plus or not. So if the clinic agree that there is clinical benefit for PGT-A Plus, it does make sense to enroll all cases as PGT-A Plus. Another consideration is when the clinic implement PGT-A Plus as their standard PGT-A workflow, there's going to be change in their requisition form and the report format. The report format, which we'll touch on a little bit later, but the TRF is relatively simple. You just check PGT-A Plus versus regular PGT-A. But if you do have interfacing with EMR, I think that does require a little bit more management. You need to contact your EMR, letting them know that the switch from Smart PGT-A to Smart PGT-A Plus so that they can make sure the mapping is done correctly in the back end. Moving on to patient education. Again, we need to let patients know what are the clinical benefits of the test. And this education will go a long way when we have the result in front of us and help the patient to interpret these additional data. Again, going back to the cost piece, if we're passing on the cost to the patient, we need to make sure the patient's aware of the benefit and the cost implication with the add-ons. There are two really good tools that our clinic use quite frequently in supporting patient education. One of which is the patient webinars. On the webinars, Igenomix talked about the standard PGT-A and the science behind it, and also some of the additional tests PGT-A Plus offer. Through the webinar, patient will have access to genetic counselors. They can ask any questions that they have with regard to the test. And also, this is a really good tool to offload some of the questions from the physician directly to genetic counselor, so that you can maintain a smooth patient consultation when we talk about PGT-A. So the next part is the expectation of PGT-A outcome and also the response to it. This is the part where I'm going to spend most of my time talking about it. So now that we have implemented PGT-A Plus, from the lab point of view, what to expect? What are the outcomes that we're expecting from PGT-A Plus? So this is an example of a PGT-A Plus report. If you do provide PN data, this will show up on the left-hand side with your trifecta biopsy and culture date information. So this will be listed under sample type. What will be new to traditional PGT-A standard report is you will now see the ploidy screening contamination detection results underneath your embryo results. So on top of euploid, high-level mosaic, and aneuploid, you will also see in bracket whether the embryo is diploid or there is contamination detected. There will be additional column on the cohort check. So this will illustrate whether the cohort check result is consistent, inconsistent, or not applicable. What I like about the report is it clearly highlights what's the test that's being done and also the reporting format. So you can see here this report includes PGT-A Plus for copy number evaluation with full mosaic reporting, ploidy and contamination analysis, and cohort check. So everything's out in the open. This will really help healthcare professional to interpret the result with the patient. If you have experience with the Igenomix report, you know that it has a lot of great information on it. And in the report, you have a lot of knowledge and information about the test that you can understand. It can help you really understand the data and interpret the result better. So just to share a couple screenshots of the report and highlight some key knowledge piece on the testing of the PGT-A Plus. So you can see here, ploidy results are provided for euploid and mosaic embryos only. So that's why when we look at the sample report earlier on for the aneuploid embryo, there isn't any ploidy screening results because only mosaic and euploid embryo will have the results. And this same test is used for detect for partial contamination. So what's important to know is both the ploidy screening and the contamination are one test, whereas the cohort check is a separate test. This will become important later on when we talk about the informative results. Switching gear a little bit on contamination. So the report also gives you recommendation of or best practice on what to do when you have contamination detected. When it's a euploid result with contamination detected, the report stated that a euploid result with DNA contamination is not conclusive, and the possibility of aneuploid, mosaicism, triploidy, or haploidy cannot be ruled out. So the recommendation here is to either rebiopsy or retest the embryo if that's appropriate based on blastocyst quality. On the flip side, if the embryo is reported as mosaic with DNA contamination, the recommendation is consider the embryo aneuploid. Going back to earlier slide when we talk about contamination, the external contamination we expect the DNA to be euploid. So what this is trying to illustrate is the mosaic result is artifact of the euploid results, euploid DNA from external DNA contamination masking the aneuploid results. So again, all the information is there. Is really informative for you to make an interpretation of the results when you get them. Similar to NGS, you will have a chance of ploidy non-informative. Basically, when non-informative happened, this brings us back to standard PGT-A. So there is no need to do a rebiopsy unless there is higher chance of triploidy or haploidy or haploidy in your in your patient population that require this test. But again, non-informative result with a PGT-A Plus add-on is equivalent to just having your standard PGT-A. So just want to share some example of what happened, and this is a real life example when you have a contamination detected. So you will first get a message from your medical science liaison, and the message basically gives you an explanation of what are some of the possible causes of DNA contamination and what should you do with the results. This is again a real life example that I have in my clinic. We identify contamination detection, and that is a aneuploid embryo. So based on the report, the recommendation from the medical science liaison is rebiopsy and retesting is not necessary, because again, going back, aneuploid result, meaning that the embryo result are most likely to be aneuploid. And again, another example here, you can see ploidy non-informative on this report. Again, this is something we sometimes see on the report. So I think it's important to understand how often or what's the prevalence of occurrence for these rare occurrence happening on your report. The majority of the time you will have a very standard report, diploid, triploid, haploid, but there is a chance where these rare occurrence would happen. Based on the Igenomix validation data they have provided at the onset of the test, they have shared that about 0.8% of occurrence of contamination detected. After about a year and over 20,000 biopsy sample tested with PGT-A Plus, the real world data that we're sitting on right now is about 0.5%. So it's good to understand what is the expectation of contamination detected. That way you can really measure your clinic against the benchmark to see if contamination is happening more often in your clinic or not, right? So this will help you, continue your process improvement to make sure contamination is avoided. And again, for prevalence of occurrence on non-informative is about 5%. I know Igenomix is working towards lowering this percent further by improving their tests. So I can expect this percentage to drop further as the tests have evolved. So again, switch gear a little bit and talk about the cohort check. These are two potential outcomes of the cohort check, consistent and inconsistent. And we're going to talk about the inconsistent a little bit later and what to do with inconsistent results. But at the same time, I do want to talk about other potential results showing up on the report. So non-informative, the cohort check can result in a non-informative results. The result does not suggest the need for rebiopsy. Again, when you don't have an informative result for a cohort check, it may means the DNA quality is not sufficient to do this SNP analysis. In that case, the result that you get is simply aligned with your standard PGT-A. So there's no need for rebiopsy just for that piece. And when there's only one embryo in the cohort check is usually not applicable. So sharing some example report, you can see here, even though I have a non-informative result with my PGT-A, I still have a consistent outcome with my cohort check. Again, the cohort check is a separate test. So you may have a non-informative results with your embryos, and then you have a consistent cohort check result. And the flip side may be true, right? You may have a PGT-A outcome, but the cohort check is not applicable or non-informative. When you have one sample that's submitted for the test, there's no other sibling cohort to compare with, so the cohort check would be non-applicable. So let's talk about inconsistent results. So how often does that happen? And I think from a lab perspective, this is something that we are hesitant. We worry that inconsistent result will show up on your report, and this will evolve into a huge investigation. So how often does it really happen? Going back to the validation study that Igenomix performed at the onset of this PGT-A test, the prevalence is 0.2%. For a clinic of our size, we submit about 2,000 biopsy sample a year for Igenomix for testing. So 0.2% equate to 4 embryos. We're talking about 4 patients, 4 couples that we have to cancel with inconsistent results. And that's a lot, right? That's going to be a lot of time that we're going to spend with the patient. a lot of time that we have to tap into our physicians to counsel the patient accordingly. So 0.2% is still a pretty big percentage, even though it seems small in a numerical way. So we delayed our adaptation of the test for 1 year. What that does is allow Igenomix to gather real-world data to really see the true prevalence of the test of inconsistent result in a real-world situation. And after a year, over 20,000 biopsy sample being tested with PGT-A, to date, there is only one reported case. So some possible cause for inconsistent results are, biopsy sample mix-up, whether it happened in the embryology lab or at the genetic testing reference lab, or embryo mix-up, which is, I think we all agree that's the worst possible situation, or pure DNA contamination. And in this particular case, it was identified through the investigation, the cause of the inconsistent result is a pure DNA contamination. So what happened with this case is the embryo, the embryo has inconsistent results, the biopsy results. So the patient signed to do a rebiopsy of the embryo that have these inconsistent results, and the rebiopsy come back consistent with the cohort checked. So the end result of this investigation is a pure DNA contamination. What that means is the embryo cell, the embryo sample, the biopsy sample, never made it into the tube, whereas a contamination or external source of DNA went into the tube, leading to the inconsistent results. So to date, this is the only case that happened with the inconsistent results. So this is really comforting in a sense that it doesn't really happen as often as the validation result earlier have predicted. And hopefully this will give some reassurance to any the audience here thinking about PGT-A Plus and adopting the workflow. Inconsistent result really doesn't really happen that often. But from a lab perspective, we need to prepare for the worst. So before you have an inconsistent result, you need to develop an action plan. So what should you do when an inconsistent result show up in your email? So you need to run through a couple of exercises. I would suggest an internal documentation review and sample traceability audit, just to pretend you have an inconsistent result and what you should do internally to review your document to ensure that there's sample traceability. If you have electronic witnessing, how to access the report and how to pull data from your system to illustrate that there is no sample mix-up within your laboratory. I think this exercise alone will help identify potential gaps in your procedures and improve your witnessing process. So all in all, this is going to improve your quality of your lab overall. What I do want to say is you're not alone in the process. You do have the support from Igenomix. When an inconsistent result happen, you will be immediately notified of the results before the report is released to the patient. Igenomix will work with the clinic to decide the best path forward for patient communication. They will immediately conduct an internal review on their genetic testing workflow. They also provide complimentary PGT-A Plus testing on the rebiopsy if that is agreed upon with the patient. Elisa and her team will share their expert opinion on the possible costs, and if there's further sample analysis needed, such as DNA fingerprinting and SNP profile comparison, Igenomix would be able to offer that as well to really solve the uncertainty and find out why there is an inconsistent results. My recommendation for the audience here, if you have an inconsistent result, be transparent, engage openly with the patient. They need to be provided with all the information to make informed decisions. Most often, having a rebiopsy done on the embryo will resolve the uncertainty, but that requires patient consent. So getting them early in on the process, in on the discussion, will really go a long way when we get to that point to do the rebiopsy. I also want to address some legal considerations. I'm sure a lot of people are thinking about the liability with PGT-A Plus. So definitely talk to your legal counsel if you have legal support within your network. Seek legal counsel. Assess the liability in case of inconsistent results. What are you liable for? But I will have to say the issue is definitely less severe in terms of a court case compared to transferring the wrong embryos. So I think we're doing good here. But again, seek legal counsel. But also want to play devil's advocate a little bit here, because if this test is so effective in identifying, potential wrongdoing, is there legal liability for not adopting this test? So I'm just going to leave that question there and let the audience ponder around this. Lastly, I want to talk about KPI monitoring and follow-up. I really love this quote from Peter Drucker: "What gets measured get managed." So, we need to track our contamination rate, haploid and triploidy rate, and the inconsistent results from the cohort check. We need to, use we can use the Igenomix dashboard and their analytic tools. Your medical science liaison would be happy to provide some analytics upon request. So it really helps us identify opportunity for protocol and process improvement. If you have a, really high contamination rate, higher than 0.5%, maybe there's room for you to improve in your protocol. So again, tracking these rates, contamination, haploid, triploidy rates, really goes a long way in improving your process. Try. There you go. So just to recap, there are 4 key takeaways here. What are the clinical benefits of PGT-A, right? Understanding the clinical benefits, the enhancement of results is reliability, and how the results support a confident decision making. Engaging your staff and patient, make sure they're well educated, equip the team with communication to make sure they can communicate the benefit clearly, provide the patient with accessible resources. What I spend most of my time talking about is the expectation and response to outcome. Have a clear understanding of the PGT-A outcome, understand and acknowledge the frequency of these rare occurrences, and define an action plan for inconsistency. Again, that's key. Be prepared. And lastly, KPI monitoring and follow-up. Track key quality indicators, and this will really help drive your lab, the quality improvement process. That's all I have, and I will pass the virtual podium to Dr. Morales.
Thank you. Thank you, Jason, for that. I think, Alyssa, you have control back of the slides.
I can advance the slides for you, Dr. Morales, but you also have control.
Oh, perfect. Thank you. If you don't mind.
Sure.
Thank you. We're going to turn our attention now to the second half of the webinar and talk a little bit about the clinical application in the IVF center when you're talking to your patients and your staff about, hey, do we transition into a new technology, and what expectations can we have for that? So we'll start off with the technological aspects. But first, next slide, please. All of us are here really just centered on this idea of PGT-A. And I always take a minute to walk back and say, what is our goal when we are doing PGT-A? And I think we can probably mostly all agree that our medical goal is to really identify and deselect blastocysts that will not result in a healthy live birth. If we can only use those embryos that we know are going to result in a live birth, that would be the true scientific goal when we're talking about aneuploid. As we know that's probably the #1 reason that pregnancies don't continue during embryo transfer. But our clinical goal is a little bit different. Our clinical goal, at least when I meet with a couple or a patient who come in for infertility, is really family planning. I want to take a larger holistic goal and say, what is the goal of them presenting? Are they interested in having 1 child, 3 children? What's their reproductive goals as a family unit? And that has changed certainly over the last decade or two, where our goal was really just the next pregnancy. What is going to give us our highest pregnancy in this upcoming pregnancy? So when we do family planning, our goal really is to select an embryo with transfer that has the highest potential for a healthy live birth. That seems pretty simple. Using evidence-based medicine, combining genomic, embryologic, and clinical data in this shared physician-patient decision-making model, all while maximizing any usable blastocysts that could potentially lead to a healthy live birth. So it's a lot of words, but it really is sitting down with the person or the couple saying, okay, how do we get to our end goal and achieve our family goals of whether you want 1 child, 2 children, 3 children, 4 or 5 children, depending on their unit goals. Next slide. So the term healthy would seem is pretty easy to agree upon, but it's actually not really. When you look at healthy, 1973, many decades ago, WHO defined it as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So that sounds like the utilitarian or an ideal definition of healthy. When it comes to live births, really we're probably looking at trying to have a birth of an infant that's alive, that's born at term, that is within the relatively normal birth parameters of 2.5 to 4 kilos, and without a major congenital anomaly. That's really what our end goal is. But because the pregnancy is a 9-month window, and different states and countries and continents measure this differently, we sometimes use surrogate markers like it's just a pregnancy, a clinical delivery, and not looking at the long-term health of the baby. So currently we use aneuploidy as one of our major markers, and we're dealing with just the genomic aspect of aneuploidy. But we do know in the future we're going to be looking at transcriptomics, proteomics, coupled with things that we're just starting to scratch the surface of, like metabolomics, epigenomics, and even pharmacogenetics, you can imagine may have some implications, as well as the whole area of uterine implantation markers that we're also just starting to scratch the markers. So there are lots of different markers that eventually one day we may utilize. All of this is with the goal of identifying an embryo that has the highest potential of a live birth. So in the last 40 years, we've really gone from just saying, has this embryo, has this egg fertilized, to now trying to impart a lot of these informations or characteristics of a blastocyst. So we now are starting to encompass bioethical principles of beneficence, non-maleficence, autonomy, and justice. And the question is, where are we driving towards trying to find this one embryo that we think is going to give the patient or the couple the best chance of a live, healthy birth? Next slide. So the evolution of technology certainly has been in my lifetime. Back in the early 80s, late 80s, early 90s, we all remember the onset of ICSI in 1989. That was amazing that a single sperm entered into an egg can develop into an embryo. But genomics really started having an influence in our lives in the embryology and the infertility worlds in the 1990s, when we started looking at older technologies such as FISH for day 3 biopsies. Then over the next decade, we all remember the decade between 2008 and 2012, where every camp had their different technology that we thought was going to be the technology for assessing genomics, from array CGH to SNPs to quantitative PCR. And each of these technologies had benefits, advantages, and disadvantages. But over the next decade or 5 years later, we all ended up with somewhat of an agreement that next-gen sequencing was probably more stable and provided the most advantages, always trying to seesaw between resolution, speed, cost, and accuracy and precision. So for the past decade or so, next-gen sequencing sort of was a platform for most genomic labs that are starting to look at aneuploidy. And then again, over the last few years, there's been a look back saying, hey, why not add a duo technology, not just the next-gen sequencing, but take advantage of the previous technologies and try to get even more information, hence the genesis of Smart PGT-A Plus, which is where we are in 2023 up until now. And you see the arrow still to the right there, because as we all appreciate, we're going to continue to have evolution of our technological advancements of not just from the genomic area, but from all the other aspects of looking at embryo development. Next slide, please. So with PGT-A results currently, as Jason mentioned, these are the routine things I think all of us have very comfortable with over the past decade, looking at euploid, aneuploid, mosaics. Even with mosaics, there's a lot of still non-uniformity of what we call mosaicism. Some genomic labs use different thresholds of 20, 30%. Some don't call any thresholds and just put them in 2 camps of euploid, aneuploid. So there's a lot still to discover about the use of mosaics, although certainly the last few years has been really reassuring as far as outcomes of using a lot of mosaic embryos. and segmental aneuploids and no results are inconclusive. So this is a current state of routine PGT-A using next-gen sequencing. Next slide, please. So the technology of this advancements is this idea of using two technologies, of using the next-gen sequencing, but doing this dual approach with the addition of SNP arrays to allow us to get further information. And when I talk to couples, yes, we went over the 3 additional pieces of information you get. You get the cohort detection as noted below, you get the contamination detected as noted, and then you get the ploidy screening. And for most of you clinically, you realize that with euploid embryos, less than 1% of these are truly haploid or triploid, so not clinically that impressive. But what I think is most important about PGT Plus is this idea of rescuing of embryos that are potential embryos to utilize. And the ideal is that, yes, we all want the 2PN that is morphologically beautiful and is a euploid with all its checks. But sometimes patients don't have the luxury of having those embryos, and they need to look at other embryos that they use. And during this meeting that we had, when we had a pre-meeting with Jason and myself, we realized how different some of the clinics are across the country. Yes, he's in Canada, and yes, we're here in San Diego. But there are a lot of centers who, as a system, only utilize 2PN embryos that go out to culture. There are other centers who have historically used 0PNs, sometimes even 1. Certainly I don't know of anyone who'd be using 3PNs from what our knowledge has been in the past. But we'll talk about that in the next few slides. But all of these are trying to identify embryos that we can use for transfer, all while maximizing anything that's available. Next slide. So this is sort of the take-home slide. If you're going to take home one slide from my aspect of the talk, this is a publication that was out in December this past year. And these are 380, a representation of 380 euploid embryos. If a center had sent these 380 embryos without any notice of the fertilization, whether they're 1, 2, or 0PNs, they would have gotten reports with the PGT-A that these were all euploid embryos. If, on the other hand, they had sent these 380 embryos with a smart PGT Plus, notifying that, yes, these were 0, 1, or 2 PNs visually on day 1, and using smart PGT Plus, this is the answers that they would have gotten. If you see on the right-hand side, these are 0 PNs. These are about 150 embryos that were 0 PNs, and 87.3% of these 0 PNs are utilizable embryos. These are now euploid embryos. About 8% of these were haploid, and the smaller 4% were triploid. So obviously we wouldn't be utilizing these embryos. And if you had utilized this embryo, obviously this either would have ended up in a negative pregnancy test or a miscarriage, which clearly is another event we try to avoid. In these 1PN embryos, about 46% of these embryos were found to be euploid diploid and potentially open for utilization. And at our lab, we call 3PNs both 2.1 and 3PNs. In this publication, they differentiated what was a 3PN, where you had 3 normal-sized pronuclear bodies, pronucleocystine, and a 2.1 where they were asymmetrical. And in this 2.1 group, 65% of them were found to be diploid. And in the 3PNs, which I guess I'm old, but I just can't believe we're talking about putting 3PNs in patients. But yes, about a quarter of them were found to be diploid. Since we've started using PGT Plus, we have not yet had a 3PN that has come back as a diploid. And so we'll cross that bridge as we get there as far as counseling of the patient, which is why this is so critical when we talk to patients about doing this. In my short lifetime in this professional area, the last 40 years, it is pretty mind-blowing to think we're talking about utilizing 3PNs when some of us are not even utilizing 0. But there were publications before this, back from 2017-18, where people were using 2 different technologies to also find very similar results using quantitative PCR from this. So for many years, we've used 0PNs without the addition and help of smart PGT Plus, and we've had certainly lots of babies born that are now reassuring to realize that they came from this large percentage that were diploid embryos. Next slide. So as far as using PGT-A Plus and its implementation, I think this is true for any new technology that a clinic uses. It's important that patients, and certainly within a clinic themselves, that it's important that everyone's aware of what the ethos, what the culture, what the procedures and policies are. As we know in our field, there's certain things that we all agree on, not all agree on, and there's a lot of gray zone, and that's where the beauty of the art of medicine comes in. And part of the beauty of the art of medicine is practicing this with full disclosure to your patients about what the policies, the culture, and the procedures are in a particular clinic. Certainly our national organizations do provide some guidelines, but they're pretty quiet on testing platforms, as this is a continually changing area. But the culture really is a reflection of the clinic policies. Maybe you live in a certain state in the United States that different countries, Canada, US, abroad. Things such as coverage benefits, certainly not a medical issue, but certainly an influence for patients in their decision making if they decide to proceed with treatment or not. And most importantly, a personalized versus a policy decision. If the goal of a particular clinic is to obtain the highest rate every single time you do a transfer, then they may err more on the side of only utilizing embryos that we have complete full confidence in. If on the other side, the goal of a particular patient who decides to use an embryo that may not be ideal, but for them this is really important and they don't have the opportunity to do another egg retrieval, they may decide they would like to use that embryo with appropriate counseling beforehand. And so within our field of IVF, we're used to this because we've had, quote, lots of add-ons that people have talked about, from sperm isolation techniques to use of ICSI versus not. You can look at the percentage of ICSI use in the United States in different states versus Europe, so different. Assisted hatching and even PGT-A. There's certainly some clinics that use PGT-A almost 100% of the time. There are others who rarely utilize it, and then there's everyone in between. Some of this has to even do with when a patient presents. Do you actively ask a patient if they have a sex chromosome preference as part of their family planning? If you do, now you've already opened the door to, hey, is there technology? Is this something we would utilize just for this preference? Whereas if they were coming in for purely infertility, that may not have been part of their thought process. So something as simple as on an initial questionnaire, do you have a sex chromosome preference of your children, really does sometimes take people into a different direction of thinking. So those are really important and subtle things that you as a group have to decide, hey, how are we going to move forward in this clinic? The other area is a big one is embryo selection. Like I said, there are some clinics who will only use certain 2PNs fertilized at the appropriate time period, and some people are using even embryoscopes and are only using embryos that develop at certain rates that they feel comfortable with. You have other clinics who, again, we all read the same data, but are utilizing more shared physician-patient decision-making as far as how to proceed forward. And then if you offer a variety of genomic technologies such as PGT and PGT-A Plus, that's another discussion you're going to be having with the patient, why one technology over the other. And again, this is what Jason alluded to. This takes a lot of time, a lot of education. We live in San Diego. I'm blessed to live here with our weather and everything else, but it's also one of the genomic centers in the United States. And so the genomic literacy of our patients is huge, from patients who are sequenced themselves and coming in and saying, yeah, I'm sequenced, this is what I have, to some people who, when I talk about genes, ask, are you talking about Levi's? So a huge genomic literacy differential in our community. And it's challenging and wonderful all at the same time, trying to talk to different patients and couples to understand how we utilize this genomic information. Transfer of non-euploid embryos. There are still centers in the United States and in Canada and abroad who don't use anything but euploid embryos. I think more and more of us are feeling comfortable with utilizing mosaic embryos as the data of outcomes continues to increase, both low and high. Utilization of segmental aneuploidy, of chaotics, and even no reads. I've certainly seen patients people who are not comfortable reading no reads. And I go back to saying, well, that's the same as if you didn't even do the test. So it's not negative information, it's just the absence of information. And even policies such as read biopsy. There are certain clinics that don't read biopsy because they feel the change in implantation rates are actually quite significant versus others. And most importantly, genetic counseling as well. Jason is luxuriously in a clinic that has in-house genetic counselors. I'm very jealous, and we are not. So we utilize outside genetic testing companies as well as independent genetic counselors when it comes to assisting us in educating our patients. Next slide. So given all this, what do we do? Do we offer and utilize PGT-A? And if we do we offer it to everybody or selectively? I think most of us that are listening to this webinar are very comfortable offering it for maternal age, some over 37, some over 35, recurrent pregnancy loss, previous failed euploid transfers. I think many of us, even if you have a young patient, if they failed 3 or 4 transfers with euploid embryos, would feel comfortable offering PGT-A, PGT-A Plus to someone who's failed transfers, repeat implantation failures. Some of us, I found out also in our preparation that Canada, you can't report sex chromosomes on the PGT reports. Here in the United States, that's not the case, obviously, so this wouldn't be relevant to them. And those are going to delay embryo transfer. We have a lot of couples who present either for social reasons or medical interventions such as chemotherapy for making embryos now, but they don't plan on using them for 4 or 5 years. At that time, they'll be 41, 42. And even though they may not use PGT at this point in their lives, they would use it later because they're not going to have another chance of the apple, so to speak, and they want to utilize and get the most information. As far as why PGT Plus as opposed to PGT, again, the clinic policy has to be clear. Do you transfer non-optimal embryos due to a patient's preference? If they're wanting to use a poor, not an ideal morphological embryo because of a certain sex selection, certainly that's going to decrease the rate of pregnancies for the clinic, but that's not ever really the goal. The goal is always what's in the best interest of the patient, and that would take a backseat into what's in the best interest of the clinic. And so those are really important parameters to have conversations about. And sometimes we have patients who want to preserve their best embryos for use in a potential surrogate if they have a significant uterine abnormality. Next slide. So specifically when it comes to implementation, as you can tell, a lot of it has to do with the process of informed consent, which, as everyone knows that's listening, is certainly a process. The process has gotten harder just because the technology aspects of this have gotten harder. But on the other hand, we have many more tools. We have we have AI, we have webinars, we have information on the internet, which plus and minus the amount of information, but that's where you have control and assistance in helping the patients understand that information. One of the pearls of implementing with PGT Plus and with PGT is we at this clinic always talk about the range of outcomes. Everyone wants to know the average, but I've yet to meet a human being who, when I tell them an average number, they put themselves below average. Everyone you meet always puts themselves above average, even though they all know what average is. So when we talk about the range of possible outcomes, I think that really helps people visualize, okay, this is the best outcome, this is the worst outcome, and somewhere in between all will fall. And that's really helpful when you start talking about embryo selection, because yes, we can all pick that perfect embryo that we know currently, but there's a lot more to that. And getting away from the idea that even with PGT Plus, that perfect embryo isn't the end all. As you know, we'll have many, many more parameters over the next 10 to 15 years of what makes an ideal embryo. Still get some patients who come in and say, what do you mean it's not 100% with all this technology? And I'm like, oh my goodness, when I started my professional life, we would be thrilled at a 10% pregnancy rate. So it shows you over time have we really increased that over the last 30 years. We certainly do a lot of teaching on genetics. When we say hi to a patient at our first visit, we utilize the idea of genetics when we talk about carrier screening, and we try to differentiate carrier screening, which are non-age related issues, to PGT testing as a genetic information about the embryo that they create that is age related. So for patients, it seems very confusing, but we really try from the beginning to set those stages as being very different. The evolution of treatments over the past 30 to 40 years, but certainly is my clinical life. There's been a huge advancement, and really an advancement also in shared physician-patient decision-making. That's really been the largest change, I think, is patients are getting much more involved appropriately in trying to understand, and they're depending on the physicians for their experience, which is not always utilizable by just looking at information. Next slide. So with our IVF patients, it's certainly part of the conversation. We talk about if the IVF cycle doesn't result in a live birth, what would be the next step? Everyone loves you when you have the baby. It's when you don't have the baby to go back and say, hey, would we do things different? What have we learned? So even here in California, we see differentials in benefits. There are some patients who don't have any treatment benefits. And a lot of people say, well, do I really want to spend the extra resources for PGT-A Plus? Is it going to help me? It's funny, we never talk about the cost. The cost of medications are huge, but as you tell patients, anywhere from 8 to 15 days you can take medicines, and we don't say, oh, I can only stimulate for 9 days because I don't have resources for 10 days. These are important things, but the benefit of PGT Plus, hopefully, as you'll realize in the next few slides, I think certainly outweighs the small increase in cost. And as far as cost goes, certainly talk to your organization and to see what that parlays into your particular area. There are some insurances companies that their goal, 2 different insurances may all cover PGT, but one insurance may only cover the next pregnancy, meaning that they don't allow you to do another egg retrieval if you have any euploid embryos that are left. I've yet to see one that says mosaics as well, but their goal is just the next pregnancy to fund the ability of the couple to get to the next pregnancy. Other insurance companies are set up that their goal is family planning. So they'll allow a couple to continue to do retrievals until they achieve their goal of family planning. Very different, medically the same, but a patient and a couple are going to make different decisions based on what may or may not be important for them. If PGT-A, we talk about the most common technology of next-gen sequencing that has thankfully been stable, at least for the past decade. And we start talking about the shift in use of combined technology. And that's really for patients to understand that, yes, PGT-A has been done for the last 8 to 10 years, same technology. We're adding another technology to help strengthen those information pieces. I think people get that, yes, the duo technology is going to be an advantage. Next slide, we heavily use genetic counselors as well. And these are clinical scenarios that we use for our coordinators, our medical science liaisons. Certainly know a lot of our staff here. We use them a lot for education of the staff. We have questions. Patients sometimes, again, I told you I live in an area that there's a large genomic literacy. We have patients requesting their raw data. I did ask Igenomix, maybe about 10% of patients ask for their raw data. And we certainly don't input it, but that's a whole nother level of discussion. Patients sometimes get results beforehand. And one of the things with this PGT Plus is a lot of the information, the report has evolved over the last 2 years. So hopefully a lot of it is not obvious, but patients can sort of find their way through definitions in the results. And we also take great pains to educate our surrounding OBGYNs, because if this is tough for us and our patients, when you get to the OBGYN community, they're also learning this new technology and how this may differ. So in this one example I just pulled, this is a euploid at 2PN. It is an embryo that contamination was detected. So the possibility is that this embryo could be still aneuploid, mosaic, triploid, haploid, we don't know. It doesn't mean you couldn't use this embryo. It means basically you don't have the information that you want in this embryo. And depending on the clinical scenario, most people may consider rebiopsying it, but some people may not choose to rebiopsy if for them, even though there's no cost involved, time would be an issue, and they may choose not to rebiopsy since it was a 2PN. And in here, you don't have the morphology, but it's an expanding blastocyst. It may be a beautiful embryo. So again, the PGT-A Plus results don't tell you what to do. It tells you what you should consider as you counsel the patients and talk to them about next steps. And the same outcomes on PGT-A results, different couples and different physicians are going to make different recommendations. And that's the beauty of this. Next slide. So in the report, it is important to place the PN status of the embryo. For example, Jason was sharing that they use all 2 PNs, so everything would be 2 PN. At our center, they may get one that's a 0 or a 3 PN, and that does impact genetic counseling because the embryo is euploid, but the ploidy status is non-informative either because of the quality of the DNA. If it's a 2 PN, I think we'd all feel comfortable utilizing that embryo. If it came from a 3 PN, certainly not something that we would currently, who knows in 10 years, but currently we wouldn't be comfortable utilizing a 3 PN where the ploidy status was non-informative from that. Next slide. The big advantage of ploidy determination, like I said really quickly, isn't the cohort or the contamination. Yes, good job, all of our clinics. We've been doing great, 1 out of 20,000. That feels really good to know that it is what we expected. Contamination, again, pretty low. Feeling very comfortable with contamination. But the big advantage is this rescue of these embryos that really are non-2 PNs. And for many of you, they may have plenty of 2 PN embryos, but for those who don't, especially as women get older, I think this is a huge advantage. Why not? Maybe it's additional 7 days, maybe a cost differential. But when you talk about cost differential, put it in perspective of all the other costs that are being utilized during that cycle. Certainly there's community and clinical experience. Although everyone wants to be an early adopter, you sometimes much better after a year or 2 has gone by and you're accumulating this evidence and feeling more comfortable. And certainly a system change is huge. Jason mentioned EMR. Next slide. I just realized time-wise we're getting along. Very quick, these represent my clinical-based opinions, but just to give you a range of where PGT Plus specifically I think would be helpful. First, really quickly, not everyone needs PGT. A young 25-year-old with tubal disease wants 1 child, wishes to minimize the number of extra embryos, maybe mini IVF, no PGT. But a 35-year-old who has 4 years of infertility with a goal of 1 child, and again, the goal is always what is the family unit building goal of that couple? They've done 1 IVF cycle with 2 euploids and 2 failed. Well, maybe some of these failed euploids weren't really, maybe 1% that could have been haploid or triploid, but if they do another IVF round, I certainly think adding an additional PGT-A Plus, maybe they had a 0 PN that wasn't utilized, that could have been utilized for another transfer would be helpful. I think this 43-year-old woman who has 3 children, non-infertile, diminished ovarian reserve, only wants to do an embryo if she can find a male embryo. Certainly using PGT-A Plus would be helpful even if she makes embryos, because if you have anything that's a 0 or 1 PN, maybe she would be interested in utilizing that embryo if that's her final goal. So again, the idea is widening the embryos that are potential for utilization is really the patient advantage, I think, of PGT Plus. So quality controls, yes, we've done a great job. We feel good about that. And it's interesting, Jason said, maybe you should be concerned if you're not using it. But certainly, I think in general, we've done a great job, and it's really reassuring that the 20,000 blastocyst data, hopefully as the next 50,000 blastocysts go, we even get better data on that. Next slide. I think that's my last slide. So the key takeaways is that you're utilizing 2 technologies for PGT-A. We continually improve our technology. This is not the last talk. 3 years from now, we'll be doing more. As most of you just saw on the web, we're even taking adult skin cells and moving forward with this stuff. Education about the utility of PGT is important. The selection of the type, I personally think it's easier as you transition to at some point just move into PGT-A Plus. My prediction, and I'm certainly not a fortune teller, but my prediction is in 2 years or so, maybe no one's offering PGT-A. Maybe all platforms have gone to this duo technology of utilizing both sets of technologies to move forward. But that's what's exciting about what we do, and I think why we all love what we do, because it is continually changing and improving patients and couples' outcomes. It's important to educate from the very beginning patients about genomics. PGT-A Plus is just a tool, another tool in our armamentarium of what we can use to identify embryos. And most importantly, this idea of shared decision-making between patients and physicians. It gets tough, but it's so rewarding to be able to help people move forward. So again, our clinical goal is selecting that one beautiful embryo that we're going to think is going to end up in whatever healthy is as a healthy live birth offspring for us. Thank you for your attention.
Thank you so much, Dr. Morales and Jason. Those were lovely presentations. We're going to open the floor to some questions and answers. Before we get there, I'm just going to highlight where you can find the recordings for the webinars that we did. The webinar from today was recorded and will be added to our website. The first two are already present, so you can navigate to igenomix.com, click on the Academy button, and then if you scroll down into this Academy page, you'll see the recordings for the first two webinars. The first one focusing on ploidy and the second one focusing on the additional QC features that are part of the test. And Jason mentioned earlier on in his part of the talk that we're here for you. Igenomix has a host of medical science liaisons as well as genetic counselors that can provide support to clinicians, whether it's the laboratory directors, physicians, genetic counselors, nurses, etc. And we have patient support resources as well. Our genetic counselors speak not only to clinics, but also to patients. And we have written resources that can help with patient education and informing too. And here's some of our contact information. That QR code there will take you to our genetic counseling webpage. This is where patients can schedule results sessions directly. And also they can register for the pre-test webinar that Jason mentioned. We strongly believe in the value of pre-test counseling. It's going to make the entire process that much more smooth. And you can also find the patient-friendly resources available on our genetic counseling website as well. And so with that, I'm going to say thank you very much. We are at time, but for those of you who can stay on, we'll take questions and answers. So we have one question already in the chat. I'm going to start with one for Jason. Jason, I'm curious to know, you're a laboratory director, so KPIs are super important to you in your role. What about the individual embryologists who are doing the biopsy? Are they worried about getting these reports and seeing an embryo that they biopsied as indicating that there's contamination present? And how do you manage those conversations?
That's a great question. I think at the onset, we really need to set the expectation for your team, right? Letting them know this is not a individual basis. Contamination is going to happen. So managing their kind of not to internalize it and say this is something that they are personally doing wrong is a systematic approach. It then, when certain individual keep happening with contamination, that's probably something you will have to address directly individually to that person. But most of the case is not going to be like that. And again, we need to work as a team to see how we can improve our process. If contamination is rate, let's talk about how we can work as a team to minimize that. Wear additional PPE, wear masks if you're not doing that. How can we alter your procedure and protocol to reduce that contamination rate? Again, going back to the point, if you don't measure that, you don't know if that's a problem within your lab that is being an ongoing issue at the background, right? So understanding that and communicating with your team, this is not personal, this is a systematic approach, and try to come up with solutions that the team can all work together to reduce that rate, and seeing that rate reducing for the team, I think that's really rewarding. So, I'm an embryologist. I tend to internalize it when the first thing goes wrong, and that's human nature. But really just setting the expectation and let them know it's not them, is the system on its own. That's my approach.
Great. Thank you so much. And Dr. Morales, you and I have had conversations before about the wealth of information that we're getting from genetics and genomics these days. What advice or words of wisdom would you provide to fellow MDs and REIs that are trying to manage this amount of genetic information?
There is a lot. 30 years ago, not too much of our conversation, now a lot of it, and it's just the beginning of it. Again, within our field, there's no practicing reproductive endocrinologist who isn't always learning. You cannot practice this field without continually being updated, whether it's through collegial interactions, whether it's through literature, whether it's through meetings, whether it's all support through different industries. But certainly the way we practice is very different 5 years to 5 years. And it's so important for structured change, because you can't willy-nilly way through this. This is, like Jason said, these are big systems that change sometimes as we decide to do certain technologies. And the variation, I think it's important to keep in fact that all over the world we want the same thing. But the way we do things in certain countries or states, we say you have to do this, you have to. You really don't have to, because you can see in other parts of the world things are happening. So it's continually being engaged at the forefront of that community, local, state, national level of how do we move forward while engaging the patients in this conversation as well. And when I talked about the bioethics, it's, what justice? The personal justice of the couple, the societal justice, where are we moving our money, where are we funding things in the state of health crisis in the US? I'm sure it's different than in Canada. All that's part of the equation. So the words of wisdom is to continue to be engaged. The fact that you're even watching this webinar, kudos to you as far as engagement. But yes, it's continued engagement.
Thank you. So one of the questions we have from our group is, I agree it is a liability to not test embryos for relatedness. However, it is an even greater risk to not test the entire cohort to the parental DNA sources. So this is about, is the embryo actually related to the egg source and sperm source? And the question is, will this be something you offer in the future? So I'll answer the question directly, since it's a question for Igenomix, but I would also be curious to hear from our guest speakers today what their opinions are on parental relatedness. It is something that we are discussing internally. We have not started with parental testing because of the additional cost and logistics that would be involved. So with the embryo samples, with the biopsy samples alone, we can do this cohort analysis. It's labor intensive and logistically cumbersome for patients and their egg sources, the sperm sources, to provide the DNA samples. And that's a requirement to do this parentage testing. You would have to get additional samples from the egg source and sperm source, and then to be able to compare that DNA to the embryos. So the internal conversation so far has been that this is more logistically challenging for us, for our patients, for our clinics, than warrants the concern. However, it's something that we're always open to considering and revisiting the question depending on market needs and demands. So just kind of curious to know from Dr. Morales and Jason. Jason, maybe you can go first, and then Dr. Morales can provide her opinion to this question.
Yeah, Alisa, I think you kind of hit the nail to the head. I think the challenge is the additional sampling from the parents of origin, and also the logistic of maintaining those samples and sending them to the testing facility. So, if you're tracing back to going with parental origin, I think that is a more comprehensive testing. But at the same time, we need to balance the feasibility in a practical sense, and how much impact it does have on your clinic workflow. So I think that's a balance that we have to strike. I think the sibling relatedness is a good surrogate indicator that all the embryos in the same cohort belong to the same DNA source, so that reduce a level of risk there. But having parental origin again would be more would be in additional to that. But we have to again balance the feasibility in the real world.
I think it's a great question. 3 steps. 1, are the cohort related? 2, is it from the parental source, not the parental, the gametal sources? And 3, so what if you're putting in the wrong embryo from a hepatical source? So the question is, going back to what needs to be measured, the reason I think that it's a beautiful addition to the PGT-A Plus and the power of the duo technology is that you get that. You didn't set out to answer that question. That wasn't maybe a problem that needed to be solved. To me, the beauty of PGT-A Plus is that you're expanding embryos that potentially are utilizable. That's the scientific advancement. That's the beauty of this. Those other 2 things are byproducts of the technology, and yes, are great, but there wasn't. It's wonderful to see that it wasn't really an issue. 1 out of 20,000. And yes, in the ideal world, you would have a system that does that. Check. Do parental? Yes, we could do that, but what cost? And we've just talked about all this, and where's the justice of that? Is that really where we want to put our efforts? But then you still have a big black box over here about the putting in the embryo. So to me, that's not really where I would spend effort at this point doing it. I mean, there's certain scenarios maybe you want to do it, but maybe that comes as a byproduct of another technology we use in the future. So I just don't see that as being the question that's dying to be answered. I think there are other things that we'll see with other technologies that it may become another product. It'd be great to check both boxes off, and at some point maybe have that third box checked off when we have, our current technologies. That certainly everyone should be reassured that the embryo going back is. There's certainly quality indicators all the way back. These are all under quality indicators. But as far as science goes, the beauty of this is the science of expanding embryos that are utilizable.
Thank you. I love that. When we get this question, it's often in the context of embryos have been transferred from one clinic to another, or maybe they were just a little bit uncertain about what happened in the laboratory, in the embryology laboratory. And there's an expansion of electronic witnessing systems now. So from our perspective, that's kind of more the angle that we're taking, is how can we support a witnessing system or additional quality control and chain of custody measurements to help that. But I fully agree with your point, Dr. Morales, that if we have a PGT-A result that says this sample is genetically related to the egg source and sperm source, it doesn't comment on which embryo was ultimately transferred and if the patient's baby is genetically related to them.
I mean, this is a perfect example when I said, if your first question, not your first question, but if your question is, do you have a preference of sex chromosome? And now you're starting to think about that. Well, invariably when I talk about PGT-A Plus to my patients, they're like, what do you mean they wouldn't be related? I mean, it wasn't even a question in their head. And now it's like, okay, well, thank God it's not an issue. I mean, the same kind of questions. There's a million questions along this chain that you can ask. So really reassuring, atta girl, atta boy. But those early adapters, they're like, oh my gosh, is this a problem that we've been unaware of? And certainly there are bad actors, there are bad outcomes, there's the one-offs. But in general, I think we can have, we should be very happy about the fidelity of what's occurred to date. I think that's reassuring.
Yeah. Thank you. Our GoToWebinar platform is going to kick us off in 2 minutes. So any parting thoughts, Jason or Dr. Morales, before GoToWebinar automatically closes?
I guess I have one quick thought. I think Dr. Morales mentioned, the technology expanding. So be prepared and embrace the technology, right? Understand the benefit of technology and also the downside of adopting technology early. So just have an open mind, right? Like to understand what the technology offers and prepare for the worst possible situation and how you can adopt the technology in your workflow. So if you're not thinking about adopting, you'll be falling behind. So start thinking, start looking into it.
Jason and I were going to try to put a wrap together for 10 seconds and we couldn't come up with the appropriate wrap. But the wrap was all about education, thinking, education, technology. Never thought in 1989 we'd be having this discussion. Hopefully in 2100 they'll be having a completely different discussion. But that's what bioethics, it's the application of this technology that's so important. Just because it's there, the question is how and when and why should we be using this technology. Thanks.
Well, thank you so much. I really appreciate your participation in this webinar today. You both are excellent speakers and we really appreciate you. So thank you so much for our attendees as well. We're going to go ahead and close the webinar today. Thanks, everyone.
Thank you. Bye, everyone.